Hello everybody, welcome to Ivy Tutoring. I'm about to give you 10 extremely high-yield questions with full breakdown to help you pass step 1. There's just one condition, and that is if you found this helpful, then you gotta like and subscribe, and if not, then just let me know in the comments how I can improve. These videos take dozens of hours to make, and I'm doing it because I wish that I had this material when I was in your shoes. So let's begin. Our first question involves a 3-day-old female infant brought to the pediatrician by her parents due to feeding difficulties. So up here I wrote, you can't pass the tube, which you can see right here, and that's extremely important. That alone should key you into the answer, but also this feeding thing is important too. So I want to explain every single malformation or anatomical variation which would cause this problem. That way on test day, you can think of these for your differential diagnoses. So first is obviously tracheoesophageal fistula with esophageal atresia. And this normally involves the frothy secretions, choking, coughing, and cyanosis, the 3 C's. Choking, coughing, cyanosis during feeds, and the nasogastric tube will coil and you have air in the stomach. And the key feature is the failure of the foregut positioning. The next condition on your differential diagnosis should be esophageal webbing or ring, and that would be dysphagia to solids and often in an older child. And this is congenital. Again, I'm telling you everything on your differential diagnosis for feeding, because whenever you see there's problems with feeding, you should think of these things. Next is pyloric stenosis. This presents with non-bilious projectile vomiting, goes all the way across the room. I've seen a practice question where they say that it hit the wall, and you have olive-shaped mass, and they're usually hungry after the vomiting. And this usually presents around 2 to 8 weeks, and it's hypochloremic metabolic alkalosis associated. You should also think of duodenal atresia, that's bilious vomiting. Next, you can think of the annular pancreas. Annular just means ring-shaped. This is where you have the pancreatic tissue that encircles the duodenum, and that can cause a duodenal obstruction and vomiting. And the last one that's associated with feeding is Zenker's. And these are just the most high-yield differential things. So Zenker's diverticulum, which is rare in infants. This would present with cough, halitosis, regurgitation, and usually it's an older age outpouching of the esophageal mucosa. So those are some differential diagnoses. So that's what we're thinking when we deal with our feeding difficulties. We have our list right here. And she was born at 38 weeks gestation via uncomplicated vaginal delivery. Her mom says the infant has cyanotic episodes during feedings and often appears to choke and cough. There's also that frothy oral secretion. And we have a healthy appearing infant and no distress. However, when she attempts to feed with a bottle, she gets the coughing and cyanosis again. NG tube is inserted, resistance is felt and can't be advanced. An X-ray is performed and shows a distended stomach with air-filled abdomen. Which of the following events most likely explains this? All right, now I'll show you the answer is indeed the incorrect partitioning of the foregut. This is classic presentation of the tracheoesophageal fistula with esophageal atresia. And this is actually the most common congenital abnormality of the esophagus. And the way that you should think about this question is you have a newborn who looks totally fine until the feeding starts. And then suddenly she's coughing, she's turning blue, she's spitting stuff out. And when you try to pass that nasogastric tube, oh no, it coils up in the upper esophageal pouch. And then the X-ray hits you with another clue. There's air in the stomach. Why is there air in the stomach? Well, there's a fistula. And a fistula is this abnormal or a surgically made passage between a hollow or tubular organ and a body surface, or between 2 hollow tubular organs. So there's a little tunnel between the trachea and the lower esophagus. And so air from the lungs is inflating the gut. And so all of this points to the embryologic misstep. It's the failure to correctly partition the foregut into the trachea and the esophagus. And so our answer is the incorrect partitioning of the foregut. Now it's good to know why the other ones are wrong. Incomplete recanalization, that would be duodenal atresia, bilious vomiting, and that would have a double bubble sign, not coughing and choking, and no end coiling. Abnormal rotation would have volvulus and bowel ischemia, so you'd have abdominal distension, not respiratory distress or with a blockage. Malformation of the pharyngeal arches would have thymus, thyroid, and ear and facial abnormalities, and failure esophageal elongation would have a short esophagus. So the bottom line is the frothy secretions and cyanosis during feeding in newborns suggest esophageal atresia due to the incorrect partitioning of the foregut. And the foregut is the anterior part of the gut. It's toward the mouth. From the distal esophagus to the first half of the duodenum. That's the foregut. If you learned something, then like and subscribe. We got 9 more just like it coming. In this question, we have a 34-year-old woman who was hospitalized with severe respiratory distress requiring intubation and mechanical ventilation due to pneumonia-induced acute respiratory failure. Her current ventilation settings include a tidal volume of 6 milliliters per kilogram and a rate of 14 breaths per minute, and the PEP of 8 centimeters H2O. And discussing the pathophysiology of mechanical ventilation with her team, the resident asked about the typical pressure changes that occur in patients' alveolar and intrapleural pressures. Which description accurately represents the expected pressures? We have our alveolar pressure and our intrapleural pressure. Okay, so whenever we're doing mechanical ventilation, the lungs fill out with air by being pushed, not pulled. And so spontaneous breathing is different. That's where your negative intrapleural pressure draws the air in, and there's a positive pressure ventilation that forces the air into the lungs. And so this then flips the normal pressure gradient, because during inspiration, alveolar pressure rises above the atmospheric, and then at the end of expiration, the PEEP keeps the alveolar pressure elevated to prevent the collapse. And now what this question's kind of getting at is even the intrapleural pressure becomes positive, especially during inspiration. So both the alveolar and the intrapleural pressure are positive throughout the cycle. And I know that can be complicated, so just bear with me for a second. PEEP stands for the positive end expiratory pressure, and that keeps the alveolar pressure positive at the end expiration to prevent the alveolar collapse. Okay, so you should be dialing in at one of the answers, and it is indeed A. And now to just make this extremely clear, when you breathe on your own, your chest pulls in air by making pressure inside of your chest negative. It's kind of like sucking air in with a syringe. That's what happens when you breathe. But when you're on a ventilator, then it pushes air into your lungs and uses a positive pressure. And that's like blowing air into a balloon. And so the key concept here is that everything gets pushed in. The alveolar pressure, that's the pressure inside of your lungs' air sacs. On a ventilator, it's positive whenever the machine pushes the air in, and it stays slightly positive even at the end of expiration if the PEEP is on, the positive end expiratory pressure, because it prevents your lungs from collapsing. That's its whole job. And then the intrapleural pressure, that's the pressure in the space around your lungs, which is called the pleural space. And normally it's negative to keep the lungs open. But with the ventilator pushing in the air, then that becomes positive, especially during inhalation. And so in this patient, they're on a ventilator, they got a PEEP, and it said to 8 centimeters H2O. And so she's getting positive pressure both during inhalation and between breaths, thanks to the PEEP machine. All right, so all these guys are wrong because they show either zero or negative pressures, which only happens in normal breathing, not when the machine is pushing in stuff. So everything stays positive. All right, so the bottom line is during ventilation with PEEP, alveolar pressure peaks positively while intrapleural pressure remains. All right, so positive is the answer. In this question, we have a 28-year-old man who comes to the clinic for evaluation of fatigue. He reports that he's been feeling excessively tired, especially in the afternoons. He denies any significant weight loss and changes in appetite, and he exercises regularly without any issues. He's been experiencing increasing thirst and urination. Father was diagnosed with type 2 diabetes at age 50. Physical exam shows a BMI of 23, and fasting laboratory results show blood glucose level of 110. Further testing indicates a mutation in the gene affecting glucose metabolism, leading to mild form of hyperglycemia. Which of the following enzymes is most likely affected in this patient? Okay, so we have some mild fasting hyperglycemia, and there's no obesity, no signs of insulin resistance, and there's positive family history of diabetes and a normal BMI, and a gene mutation that maybe affects the glucose metabolism. And all this makes us think of maturity onset diabetes of the young, particularly MODY2, which involves a mutation in glucokinase gene. And so some really important kind of buzzwords for this question are the mild fasting hyperglycemia. That's stable and often asymptomatic. And he's a young, non-obese patient. That suggests that it's not type 2 diabetes. There's a family history that suggests that it's autosomal dominant maybe. And then maybe there's a gene affecting the glucose metabolism in there. We think of the enzymes that are affecting this, like glucokinase is one of them. And so in MODY2, we have a glucokinase gene that mutates and it leads to impaired insulin secretion threshold. This is autosomal dominant, and it may not require treatment unless there's like a pregnancy or some other risk factors. And this is often discovered incidentally or during pregnancy. And the pathophysiology is that we have glucokinase, which is the glucose sensor in our beta cells, and it phosphorylates glucose. So now we get glucose 6-phosphate. And so if we have a mutation, then glucokinase has a higher threshold for sensing glucose. And so the result is you have delayed insulin release, and so the blood sugar stays mildly elevated. And that leads to stable, mild hyperglycemia, and often it's non-progressive. So it's the glucose sensor that's messed up in the pancreatic beta cells. And it leads to higher glucose thresholds for insulin release, and so it's kind of stable up there. Why is it not hexokinase? That's involved here. Yeah, that's found in most tissues, but it has a low Km for glucose, and it's not the sensor for the beta cells. So that's not the answer because it doesn't match the beta cell-specific sensing defect. Isocitrate dehydrogenase, that's a TCA cycle enzyme, and acetyl-CoA carboxylase, that's in fatty acid synthesis, and your PepsiK is involved in gluconeogenesis, not related to sensing glucose or insulin release. And this is important because many people think diabetes always comes down to just insulin resistance or autoimmune destruction, but sometimes the pancreas just does not notice the sugar until it's a little bit too high, and that's MODY2. That's what this dude has. So I think the hardest detractor here is hexokinase, because these are both enzymes that phosphorylate glucose to glucose 6-phosphate, which is the first step of glycolysis, but they have very different behaviors depending on where they're found. So hexokinase is located in like the brain, the muscles, the fat, tons of tissues, and it phosphorylates even very small amounts of glucose very quickly. So the Km is low, it's got a high affinity for glucose. That's what that means, the Km being low. And it works even when the glucose is low, and it's inhibited by its own product. In contrast, glucokinase is the sensor guy, right? It's found only in the liver and the pancreatic beta cells. That's super duper important. Liver, pancreatic beta cells, glucokinase. Its function is it acts as a glucose sensor and it controls the insulin release in the beta cells. And the Km is high, so it has low affinity and it only works when glucose is high. It's not inhibited by its own product. It keeps going even if the glucose is high. That's the big difference between these guys. Just wanted to kind of explain that briefly and then say that glucokinase mutation leads to mild hyperglycemia and increased thirst and urination in young patients. Wow, check this out. I think it's kind of funny that I'm on the photo like that. Okay, our next question, we have a 5-year-old boy who's brought to the clinic by his mom due to recurrent skin infections and persistent cough over the last 6 months. Medical history is significant for several hospitalizations due to severe bacterial infections, including hospitalization for pneumonia caused by Burkholderia, and he's been treated for abscesses caused by Staph A. He has mild hepatomegaly on physical examination, but no lymphadenopathy is noted. Lab tests reveal normal levels of IgG, IgA, and IgM. Neutrophil function test shows impaired respiratory burst activity. That was really nice of them. They didn't have to say that, but basically we got a kiddo here. He's got recurrent catalase-positive bacteria infections, especially Burkholderia, and he's got impaired respiratory burst, and so all of that is like a dead giveaway for chronic granulomatous disease. So his immunoglobulin levels are normal, which rules out any humoral deficiencies, and CGD results from a deficiency in NADPH oxidase, and that's going to be the answer here. It's chronic granulomatous disease. All right, hyper IgE would be Job syndrome. That's going to present with eczema, retained primary teeth, and very high IgE, obviously. Hyper IgE syndrome in the name, and it's recurrent skin and lung infections. But that would have very high IgE and coarse facies, and that's not seen here. All right, what about common variable immunodeficiency? Well, that's the low IgG and IgA and recurrent simulpulmonary infections. But this patient's immunoglobulin levels are normal, and that's the reason why it's not common variable. The answer is indeed C. Severe combined, that's severe infections in the infancy and failure to thrive in lymphopenia. But this patient's 5 years old and he has normal IgG, and so it's not profoundly immunocompromised, and so definitely not D. Ataxia telangiectasia, that has a triad associated with it. It's the ataxia, so cerebellar ataxia, and then the spider angiomatas, the telangiectasias, and also the low IgA. And there's no neurofinding and no telangiectasias, and so that's not the answer. So anytime you have a child with recurrent severe infections but catalase positive, that's the very important part. Catalase positive organisms like Staph aureus, Burkholderia, then the step 1 radar should be lighting up. You should be like, oh my gosh, this happened because the neutrophils can't perform the respiratory burst. And so there's a defect in NADPH oxidase, and that causes chronic disease. Usually it's X-linked. So impaired respiratory burst indicates CGD, leading to recurrent bacterial infection. In this question, we have a 12-year-old girl coming to the emergency department because of frequent urination, increased thirst, and unintentional weight loss over the past month. On physical examination, she appears mildly dehydrated, but the exam is otherwise unremarkable. Lab tests show a serum glucose level of 400. A urine analysis shows 3+ glucose and no ketones. Which of the following renal transport mechanisms most likely contributes to her findings? Okay, so we have a serum glucose of 400, and so the kidney's SGLT2 transporters in the proximal tubule are going to be overwhelmed, and so they can't reabsorb all of the glucose. And so once they're saturated, the glucose appears in the urine, and it leads to osmotic diuresis, polyuria, and dehydration, and that's why glycosuria occurs in uncontrolled diabetes. So let's look at these answers. Decreased activity of the sodium, hydronium, exchanger. So that's involved in acid-base handling, not glucose stuff, and so I just would not choose that as the answer. Inhibition of sodium potassium ATPase pump. Well, that provides to the sodium gradient indirectly by powering the SGLT, but it's not going to supply the saturation itself. All right, C is our correct answer because glucose is reabsorbed in the proximal tubule via the SGLT2. D, aquaporin stuff. That's in the collecting duct stimulated by ADH. Nothing there. Dysfunction of the proximal tubule by carbonate reabsorption. That's seen in Fanconi syndrome or acidosis compensation, no link to hyperglycemia or glycosuria. All right, so really quickly, let's talk about 1 versus 2. So SGLT2 is located in the early proximal tubule, and then SGLT1 is going to be in the late proximal tubule, the S3 segment. And this guy does like 10% of it, and this guy does like 90% of the filtered glucose reabsorption. And one has a high affinity and low capacity, and this guy has a low affinity and a high capacity. And really, SGLT1s, there are no pharmacologic targets there for DM drugs, but the SGLT2 inhibitors would be like the flozins. And the 2 is only found in the kidney and the proximal tubule, and the 1 is found in the small intestine as well. All right, in this next question, we have a 7-year-old girl who was brought to the clinic by her parents due to progressive weakness and difficulty walking. On a physical examination, she has decreased deep tendon reflexes and muscle weakness in her lower extremities. Her medical history is significant for cystic fibrosis, and recent lab shows that there's low serum concentrations of fat-soluble vitamins. Which of the following processes is most likely impaired, contributing to her current condition? All right, we got a lot of answers here. But in cystic fibrosis, we have a thickened secretions that block the pancreatic enzymes like lipase. And lipase is required for fat digestion. And without proper fat digestion, the micelles can't form. And micelles are the aggregate of molecules in a colloidal solution. But basically, in simple terms, they are tiny particles that are made of substances that are soluble in water and that come together to form a little ball. And they can carry other little substances inside of them. And so they're formed in the digestive tube as a result of the interaction of water molecules, fats, and fat-soluble vitamins in the blood and in your food, and the bile salts produced by the liver. And so the bile salts emulsify, and the lipids of food increase their solubility and absorption by the intestine. And so if you don't have fat digestion, you can't form micelles. And so fat-soluble vitamins like A, D, E, and K are not absorbed. And so the child's symptoms of neuromuscular weakness and areflexia point to vitamin E deficiency, which is definitely going to be tied to the formation of your micelles. Now, why is it not the absorption of the amino acids? Well, protein digestion is typically found to be normal in cystic fibrosis, and it doesn't explain the fat-soluble vitamin deficiency. Why isn't it the formation of the chylomicrons? Well, the chylomicrons package fats after reabsorption, and this issue is before the absorption, so it can't be chylomicrons. Sodium-dependent is used for glucose, amino acids, not fat-soluble stuff, in the synthesis of ceramide. Well, ceramide is part of the sphingolipid metabolism, and the sphingolipids are just those compounds which are fatty acid derivatives of sphingosides, and they occur chiefly in the cell membrane of the brain and the nervous tissue. They're not involved in the fat-soluble vitamin absorption. So the most important stuff here, this is the pathophysiology if you want to read that, but this guy's got cystic fibrosis and some progressive weakness, and it makes you think of a fat-soluble vitamin deficiency, especially vitamin E, because of those symptoms that are neurological in nature. And the reason you can't absorb the fat-soluble vitamins is because you can't form micelles, the tiny little guys made of bile salts that trap the lipids, and they shuttle them to the intestinal wall. And the whole reason here, the pathophys, is that in CF, you have the thick mucus that blocks the pancreatic lipase, and so the fats cannot be digested. If that digested, there's no micelle formation, and so vitamins E, D, E, A, and K cannot be absorbed. All right, the bottom line is impaired micelle formation leads to malabsorption of fat-soluble vitamins in cystic fibrosis patients. All right, our next patient we have 35-year-old man presenting to the clinic with a 2-week history of progressive difficulty lifting his arms and his legs, accompanied by also a new rash. And the rash initially appeared as reddish-purple spots on his knuckles and has since spread to his upper chest and his neck. He has no significant medical history, and he's not on any medication. Physical exam reveals erythematous plaques on his knuckles and a heliotrope rash. Heliotrope is just the violaceous, dusky erythematous skin eruption with or without edema, and it's symmetrically involving the periorbital regions and also sometimes the forehead as well. So that's what heliotrope means, the heliotrope sign. And it should definitely cue you into dermatomyositis. And indeed, our answer is dermatomyositis. Okay, so he's got the hallmark features of it, like the proximal muscle weakness, the Gatron's papules, and the heliotrope rash. Elevated CK also confirms a muscle injury, and the combination of the cutaneous findings and myopathy rules out polymyositis, which lacks the skin findings, and it makes dermatomyositis the correct answer. All right, so polymyositis is a proximal weakness without a rash. No rash there. That's why it's poly, not derm. So you have those Gatron papules. And the Gatron papules are the small, raised, reddish purple bumps that appear typically on like the knuckles, elbows, and the knees in individuals with dermatomyositis. They're raised bumps. That's what a papule is, reddish purple. And they can also be kind of scaly, but they're often located on the prominences. And this is an autoimmune disorder, and it affects the muscles in the skin. And the exact cause is unknown, but we think that it's related to inflammation and immune system dysfunction. All right, how about myasthenia gravis? How's that for an answer? Well, no. Have you have fluctuating weakness and ocular involvement and no rash? There's no CK elevation or rash there. So myasthenia gravis affects the neuromuscular junction, so it's not the answer. How about systemic sclerosis? That's tight skin sclerodactyly, which is just the hardening and the tightening of the skin of the fingers and the toes. That's what the body has, prepares too much collagen and it causes fibrosis. So not that, no Raynaud's, nothing like that. Erythema multiforme has the target lesions, often after HSV and certain drugs, and the skin findings just don't match that. So the purple rash on the eyelids and the red bumps, dermatomyositis. So that heliotrope rash and proximal muscle weakness indicate dermatomyositis as the diagnosis. That's the bottom line, folks. All right, so here we have a 67-year-old man with a history of hypertension and dyslipidemia presenting to the emergency department with a right-sided weakness and difficulty speaking that began 4 hours ago. He's been taking nalopril and torvastatin regularly. On examination, his blood pressure is 145/85, and his pulse is 130 per minute, and it's irregular. And there's a right-sided facial droop with a 2 out of 5 strength on the right upper and lower extremities. His speech is slurred. A head CT scan shows no acute intracranial hemorrhaging, and an ECG reveals an irregular rhythm with the absence of P waves. All right, so that is very, very generous of them to give you, because due to this, we know that it's atrial fibrillation, and it's going to be an acute embolic stroke because he has got 4 to 5 hours of symptoms with no hemorrhaging on the CT, and so it's the criteria for TPA. And that can restore the perfusion and also improve neurological outcomes. All right, so which one would actually improve the stuff? How about a beta blocker? Well, that's just used for rate control in AFib. And it doesn't actually address the stroke, and it could actually worsen the hypotension and the cerebral perfusion acutely. How about calcium channel blocking? Well, that would be used for rate control as well, and it's not appropriate in acute strokes. There's no neurological benefit from that. So what's the reason you're doing that? Statin loading dose. That is used in stroke secondary prevention, not acute treatment, and it does not improve immediate neurological function. You need fibrinolytic therapy. How about low molecular weight heparin? Well, that is used for DVTs and pulmonary embolisms. This is not the first line for cardioembolic stroke stuff. It's contraindicated acutely before imaging, excludes the bleed-in, and is not shown to improve the function immediately. So don't do that one either. Here's the explanation and some of the kind of trap answers and why they're wrong. But basically, atrial fibrillation is the most common cause of embolic stroke. So if a patient shows up with like a sudden onset of weakness and slurred speech and irregular rhythm, then you should think of a cardioembolic stroke. And the window of treatment is super duper short. You've got 4.5 hours to give TPA and rescue the brain tissue. And I do also want to mention like how TPA works because I think that's kind of cool and important. So TPA stands for tissue plasminogen activator, and plasminogen is just a fancy word for the inactive precursor of the enzyme plasmin. And so this is a serine protease that turns plasminogen into plasmin, and then it dissolves the fibrin clots. Okay, so what happens is you have your fancy TPA, and that binds to the fibrin inside the clot, right? And it activates plasminogen and turns it into plasmin. And plasmin digests fibrin, and it breaks down the clot. And then blood flow is restored. So it's a clot buster. It restores perfusion to the ischemic tissue, it reduces infarct size, and improves neurologic recovery if you give it early. You got to give it early, though. There's ischemia. Time is tissue, baby. The bottom line is fibrinolytic therapy is crucial for acute ischemic stroke within 4.5 hours of symptom onset. There are some risks, though, like intracranial hemorrhaging. So it's contraindicated if you have an active bleed, history of hemorrhagic stroke, maybe some recent surgery or trauma, and if the blood pressure is 185 over 110. So there are some contraindications, but in this case, he's within all the windows. We're good to go, and it ought to be given, and it'll be life-saving. So if you spot a stroke, then give TPA before the brain croaks. Wow, I'm a poet. I didn't know it. All right, hopefully you guys are ready for the freaking coolest question ever. We have a 45-year-old woman with a history of type 2 diabetes presenting to the clinic with muscle weakness and exercise intolerance. Further evaluation reveals a mitochondrial disorder, and you decide to educate her about mitochondrial genetics and explain the mitochondria and why they have their own genetic material. Which of the following is the primary reason for mitochondria encoding their own tRNA? So I'm going to quickly give you guys the answer, but then I'm going to dive into this because this is fascinating. So the mitochondria utilize a unique genetic code that differs from universal genetic code. Okay, so this is one of the times that evolutionary biology really comes in clutch for step one. And as many of you guys may know, I actually studied evolutionary biology at Harvard, and I think mitochondria are some of the clearest and most powerful evidences. Actually, not powerful. There are plenty of examples. Endogenous retroviruses is the most powerful. But mitochondria are super powerful evidence for the theory of evolution. And basically, they are living proof that eukaryotic cells evolved from ancient symbiotic relationships. And this theory is endosymbiosis. And basically, what it says is long time ago, a large primitive eukaryotic ancestor engulfed a smaller anaerobic prokaryote, right? So eukaryotes, again, just basic biology here, they're organisms that have membrane-bound nucleus that contain the genetic material, DNA, and other specialized membrane-bound structures called organelles. Okay, so like animals, plants, fungi, these guys are all eukaryotic. Even a protist is eukaryotic. And their cells are large and they're complex, more complex than a prokaryotic cell. That's a eukaryote. And so one day, a big old eukaryote, one of our ancestors, was just chomping up a small aerobic prokaryote, likely alpha proteobacterium. And instead of just destroying this, the two formed a symbiotic relationship. You help me, I help you. So a small bacterium helped to generate ATP for the host. Wow, thank you. I love ATP. In return, what does the ATP guy get? A stable environment and nutrients. Wow, it's synergistic. Okay, so that didn't just have to happen like randomly by chance. Now you get a favorable organism, which now has ATP inside of it. And now the aerobic prokaryote has a little shell. It's got a stable environment where it can do its thing. And so over time, this bacterium becomes the modern mitochondria. Okay, and it has its own circular DNA. Just like bacteria, it's nonlinear, and they've got their own 70S ribosomes. It's the same size and type as the prokaryotic ribosomes, right? This is mitochondrial evidence for evolution. Also, binary fission occurs. So mitochondria replicate like bacteria, not via mitosis. Also, they have the double membrane. So the inner membrane is from the engulfed bacterium, and the outer is from the host cell. Look at that. Also, they have smaller gene sequences. Mitochondrial genes are closest to the alpha proteobacteria, and that's the reason why we think it originated from them. And then lastly, the maternal inheritance. There's no recombination. It's just passed clonally, and that allows tracing ancestry, like mitochondrial Eve. Okay, so that is like super cool. And if people understood that, then they would understand a lot more about science and the world and their religion, and just they'd be so enriched to know exactly why the mitochondria gives us evidence for the theory of evolution. And mitochondrial diseases show maternal inheritance. And so basically what that means on step one is all the kiddos from an affected mother are going to get the disease. And so drugs that inhibit prokaryotic ribosomes, like tetracyclines, may affect the mitochondrial translation. And so mitochondrial DNA mutates faster, which is useful in phylogenetics and evolutionary timelines. Okay, and why does this matter? Really quickly, let me do this because I freaking love evolutionary biology. This provides a direct molecular and structural evidence that complex life evolved via symbiosis. So the mitochondria and the chloroplasts in plants support this theory. And so this shows how prokaryotic life forms merged to create complex eukaryotic cells. Okay, why else would mitochondria look, replicate, and function just like bacteria? Well, it's because they used to be bacteria. They're a living fossil inside of your body that proves complex life evolved from simpler organisms that work together. Okay, so a primitive eukaryotic cell engulfed the prokaryote, and that prokaryote became the mitochondria. And so all you really need for this to happen is you need a nucleus and a cytoskeleton, and then you need a free-living prokaryote that makes ATP. And then that immediate symbiosis forms over millions of years. The prokaryote loses the independence and becomes a mitochondria. Okay, so a mitochondrion is an organelle inside of a eukaryotic cell. It's the powerhouse of the cell. It makes the ATP. And it still has prokaryotic features, but it's no longer an independent cell. And so today, mitochondria are not like prokaryotic cells anymore, but they are descended from one. And that's why they have circular DNA like bacteria. That's why they had the 70S like the prokaryotes. That's why the membrane is double membraned. That's why they divide through binary fission like bacteria, not mitosis. That's why the genetic code is slightly different, and that's why the inheritance is maternal only, whereas the whole eukaryotic cell is diploid, has a maternal and a paternal. And so mitochondria are clearly prokaryotic in origin, even though they now live inside of a eukaryotic cell. Now, guys, that is fascinating stuff. And so the answer is the mitochondria utilize the unique code that differs from the universal genetic code. All right, and that's the bottom line right there. Cool beans. And thanks for indulging me there. Let me know if you like those tangents, because I love talking about evolution and biology. I even wrote a book about it. Maybe I could put that on the channel or give you guys a huge discount so you can read that book. But it's called Did We Evolve? Spoiler alert, the answer is yes. It is fascinating. What a beautiful thing. Doesn't that just get you jazzed up? Doesn't it want to make you just start a YouTube channel and just talk about this? Oh, I love it. All right, I digress. Our next question, we have a 52-year-old woman presenting to the clinic with complaints of intermittent flank pain and unintended weight loss over the last 3 months. She also reports noticing some episodes of blood in her urine. She has a 30-year pack history and drinks alcohol occasionally. Physical examination reveals tenderness in the left flank. Lab studies show normal renal function, but a hemoglobin level of 18 grams per deciliter and a serum calcium of 11.2 milligrams per deciliter, and a contrasted CT scan of the abdomen shows a large, solid mass in the right kidney with an area of necrosis. A biopsy is performed, and histology reveals nests of cells with abundant clear cytoplasm. Which of the following is the most likely diagnosis? Okay, so we got a couple of things. We got a triad for renal cell carcinoma, right? We have flank pain, ouch, we have hematuria, and we have a mass. And we also have some paraneoplastic signs like polycythemia from the elevated EPO and hypercalcemia from the elevated PTHRP. And so histology shows the clear cells with this, which is just pathognomonic for the name, right? It's clear cell subtype of renal cell carcinoma. And the risk factors are smoking, and also in imaging, you have a solid mass with necrosis. So all of that totally fits. But let's talk about why it's not some other stuff. Whoa, what about this? Chromophobe. Okay, that's kind of weird and confusing. Basically, we just put that there because it is weird and confusing. And this is the pale eosinophilic cells with perinuclear halo. This is not a paraneoplastic syndrome. And so our answer is indeed just a renal cell carcinoma. Always go with the basics. Go with what you know on this test, and you'll be just fine. C is transitional cell carcinoma. This is a urothelial carcinoma, and this arises from the renal pelvis, and it would have painless hematuria and no paraneoplastic syndromes. Oncocytoma is benign, mahogany brown tumor, and angiomyolipomas would be benign tumors of the blood vessels and smooth vessels in the fat associated with tuberous sclerosis, like a fatty tumor, not the clear cells of paraneoplasms. So the big things here, the big takeaways are the hematuria, the flank pain, and the weight loss. Hematuria, by the way, is just the presence of blood in the urine. And so that's the triad. And it's a triad because it's 3 words, renal cell carcinoma. All right, it's a triad. And so you add in the hemoglobin of like 18 and the calcium of 11.2, and that's paraneoplastic effects of EPO. And it's just all going to be telling you, man, we got renal cell. And especially that solid mass with necrosis. And I wanted to just end this video by talking about paraneoplastic syndromes because they're super highly tested on step 1 and step 2. And they're all over medicine, right? Especially in oncology, if you want to be like Watson in-house. But paraneoplastic syndromes are the systemic effects that are caused by the tumor-secreting hormones and the cytokines, the immune associations. It's not due to local invasion or metastasis, right? So they're remote effects of cancer. And it's often the first clue that there's a malignancy. All right, so the high-yield paraneoplastic syndromes by tumor type, small cell, lung cancer, carcinoma, and that one has polycythemia, hypercalcemia, hypertension, and Cushing's, right? So polycythemia from the EPO, calcemia from PTHRP, parathyroid hormone-related protein, and hypertension through the renin, and the Cushing's through the ACTH. There are also gynecologic or breast cancers. So like ovarian teratomas, those have anti-NMDA encephalitis. Breast cancer would have dermatomyositis associations, and endometrial cancer, acanthosis nigricans. There are also some hematologic malignancies that cause different syndromes like Hodgkin's lymphoma cause increased 125 vitamin D to hypercalcemia. Thymomas can cause myasthenia gravis, leukemia. And there are some other classic associations like pancreatic cancer would have migratory thrombolytis. That's the Trousseau sign. And gastric adenocarcinoma would cause acanthosis nigricans. And medullary thyroid cancer would cause increase of calcitonin and hypocalcemia. And hepatocellular carcinoma would cause elevated EPO, and polycythemia is just the abnormally high number of red blood cells in the blood and is the primary disease, or it's a secondary condition like living at high altitude or something like that. Okay, so small cell in the lung is ACTH and SIADH. Clear cell, renal cell carcinoma, would be EPO and parathyroid hormone-related protein. Pancreatic would be Trousseau's, thrombosis. Renal would be renin and EPO. Cervical and ovarian would be anti-NMDA. Encephalitis would be, and you have other conditions that we kind of talked about there. Encephalitis, Lambert-Eaton, all that stuff. All right, so this can actually precede the cancer diagnosis and it helps to identify the hidden malignancies, right? So super important to keep your eyes out for those syndromes. Bottom line, clear cell renal carcinoma is indicated by renal mass in the clear cell cytoplasm, hematuria, and hypercalcemia, and that flank pain. All right, guys, look at all those notes that we've taken here. Have you learned something today? If you did learn something, then please be sure to like and subscribe. I really appreciate it. It's so fun creating this community for you guys. Look out soon. We'll be launching our website, ivmed.net. We're making it free. It's a free resource where I've typed up a database of everything you need to know about every single condition on step 1. Also, I'm uploading practice questions. And I also just recently launched a Discord, and I'm looking for somebody to run that Discord. So please let me know if you're interested in that. Basically, it's a free space where everybody can study together, be like, oh my gosh, I hate step 1 too. Let's be friends. I don't know whatever you guys are going to do on there, but it's a little Discord. There's a Telegram, and I'm going to start an Instagram, a whole bunch of other things. Just click those links in the bio, and thanks so much for being along for this journey. And also just treat yourself. Go out there and do something fun today. Good job watching this video. All right, this isn't the funnest stuff to watch, and I'm trying to make it as fun as possible, but like, you know, good job. So hopefully you guys have a great rest of your day. Make sure you're studying a lot, and we'll see you guys in the next video.